Good afternoon, everyone. Welcome and thank you for joining us. I'm Cassandra Williamson-Hopp, the conference editor of Benefits Canada, and your host for today's webinar. New specialty drugs deliver patient benefits, but also impact private health benefits plans. Benefits Canada's Drug Innovations webinar series provides insight into new drug introductions, where attendees can hear directly from experts about new medications and the diseases they treat. Today's digital event, sponsored by Sanofi Genzyme, will discuss ATTP, a rare, life-threatening emergency blood disorder that typically occurs in the young, working population and has serious long-term impacts if not treated quickly. It will also address how ATTP and the first targeted therapy approved for this condition may impact your group benefits plans. Just a few housekeeping notes before we get started. This is an example of an attendee interface. You should see something similar on your own computer desktop in the upper right-hand corner. Please use the orange arrow to open and close your control panel and the audio tab to select your preferred audio, either mic and speakers to use your computer audio or telephone to dial in using the information provided. If you have any questions for today's presenters, please type them into the questions pane of the control panel. You can send in your inquiries at any time. We'll be collecting these and addressing them during the Q&A session at the end of today's webinar. To begin, let me introduce you to our presenters and explain the slightly different format of today's webinar. We'll start off with a patient advocate, followed by a brief live audience Q&A session. We'll then hear from Dr. Louise Girard, nephrologist and clinical associate professor at the University of Calgary. Dr. Girard will be co-presenting with Dr. Raul Bohra, medical science liaison for rare blood disorders at Sanofi Genzyme. We'll then have another round of Q&A from our live audience. Without further ado, I'll hand the floor over to our patient advocate. Please note that for confidentiality purposes, we've blurred the webcam and removed the patient's name.
Hi, I was diagnosed with TTP 2008, and it has been a journey for me. I've relapsed 3 times during this course, and I'd like to focus on 2008. That was my worst year. I relapsed. I ended up in the ICU, and when I woke up, it was 5 days later. I'm very grateful to the doctors and nurses that took care of me and found a drug that pretty much saved my life. I couldn't afford the drug, and Dr. Pravinsky had to advocate on my behalf so I could get this drug to save my life. I'm very grateful to the team at St. Mike's for saving my life, because before 2008, I thought I was in perfect health. And this has been a journey for me. The blood transfusion, the plasma transfusion, the rituximab, and this drug. I'm not sure if you could see it, but it saved my life. And I've been in remission for the last 2 years. I'm not sure when I'm going to relapse again, and that's always on my mind. But if we don't have a drug, or if we can't afford a drug that can save me, I really don't know. Well, I pretty much know what the end result would be, because they had to save me. They pretty much said they had to save my life. And without the drug, moving forward, if we can't afford the drug, I'm not sure what the outcome would be for me other than death. So again, I really appreciate and grateful to the team at St. Mike's for saving my life. And I'm really trying to hold it together, because it's an emotional journey for me, because every day I have to live with, am I going to relapse tomorrow? But so far, for the last 2 years, I've been holding my own. But that's checking in maybe monthly to do blood work to make sure my platelets are intact. So there's not a day that I don't go without thinking, am I going to relapse? It's a hard journey. And the hopes is that this drug will be available for patients like me and make it accessible for us so that we can pretty much live another day. Thank you.
Thank you so much for sharing your story. I really admire your bravery, and I know how difficult that must have been for you to tell. So I really thank you. I'd now like to open up the next 5 minutes to have our patient advocate address some questions from the live audience. I have one for you. What has helped you in your journey to diagnosis and treatment? Patient, are you still here? Hello? Okay, maybe she needs a couple minutes. In that case, maybe we'll just move forward with the rest of the presentation and see what happens next. So without further ado, I'd like to hand the mic over to Dr. Gerard and Raul.
Great, thank you very much. I'm just trying to wait for control here. There we go. Sorry about that. So as was mentioned before, my name is Louis Gerard. I'm a nephrologist from Calgary. I actually spend the bulk of my time doing rare diseases. So I actually treat inflammatory diseases of the kidney. And I'm also the medical director of our plasmapheresis unit. And that's one of the treatments that our patient advocate mentioned. That's the foundation of treatment for the condition that she has. She certainly delivered a powerful presentation, and you can see just from her emotion the impact that it has had on her and on her life. And I would submit to you that that journey is the common journey for patients with this rare disease. So we want to take the next number of minutes to go over the disease in a way that I hope helps you to understand what's going on with her and other patients who have it. We'll also be discussing the current standards of care and how the new medication she mentioned, caplacizumab, fits into the armamentarium of therapy as it pertains to this medication. Please, if you have questions throughout, submit them in the chat and they'll be collated at the end for the question and answer period. So she mentioned she had a condition called TTP. So TTP stands for thrombotic thrombocytopenic purpura, which obviously is a mouthful. But basically that means it's a disease of clotting of the small blood vessels that results from a special dysfunction in the platelets. And the platelets, as many of you will know, are required for clotting, but when they're overactivated, they can cause significant disease. And acquired means that this condition is generally an autoimmune disease. So your body is fighting, your body's immune system is fighting itself. As I go through this, I want to give you a superficial overview of how that actually occurs, because it's interesting to see that, but it also will help explain how this new therapy works as well. So as the patient advocate mentioned, prior to modern therapies, the mortality rate in this disease was 90%, and actually greater than 90%, I would say 95 to 100% fatal. So we've certainly been able to impact that with the current standards of care, although as you'll see further in the presentation, the mortality rate actually dropped or is still around 20%. As was mentioned in the introduction, it tends to occur in young patients, so 30 to 50 years of age, and it is a rare disease. So in Canada, there's currently 170 prevalent patients, and this was from 2017 data. Here is the mechanism of action, which we'll get into further, but it's from uncontrolled formation of little clots in the blood vessels. And you can imagine all of your organs have little blood vessels. So you can be clotting your kidneys, you can be clotting your brain, you can be clotting your heart. So of course, the burden of this disease can be significant. So acutely, because of the clots and the lack of oxygen or ischemia to the organ, you can get heart dysfunction, brain dysfunction, and kidney dysfunction, which will manifest itself as heart attacks, heart failure, strokes, and acute kidney injury, meaning your kidneys are damaged and frequently require dialysis. And as I mentioned a few minutes ago, the death rate remains around 20% with this disease, despite the standard of care therapies. In terms of long-term consequences, and given this is a talk to Benefits Canada, is these are young patients, so you can imagine the morbidity and disability that occurs from a disease like this. So patients may be left on long-term dialysis, which we all know is a terrible outcome from a working perspective and a quality of life perspective. Heart failure, which is equally as devastating. One of the issues that frequently impacts these patients are cognitive issues, so troubles thinking, mental health issues such as depression arising for their disease, and also having the sequelae of stroke, so paralysis, etc. And all of these things combined certainly lead to a shorter quality of life, but also a shorter life expectancy as well. So I want to spend a little time talking about mechanism, and I realize that people on the line are not physicians or clinical, but I think it's important to talk about this superficially just so you understand how the medication's working. So I'm going to show you a blood vessel here. So the blood vessels here would be any blood vessel in your body. And what happens is a clot forms, and the clot is represented by this red line with the purple structures around it. So the purple structures are platelets. So what happens is this clot, you can see, is blocking the blood flow, and that would be blood flow going into an organ. So again, that would lead to brain disease, heart disease, gastrointestinal disease, kidney disease. I'm going to show you a few animations to make this a bit more clear. So we're going to be focusing here where the red box is. So in your blood, you actually have these red lines here. And again, we don't need to know the name, but the red lines serve as a scaffold for platelets to accumulate on. And it's important for you to be able to form clots. So say you had a puncture wound or something like that, you definitely want to form a clot, but you want to form a clot in controlled circumstances. And so these green cowboy hats, which I'll refer to as green cowboy hats later, but they're called ADAM TS13 molecules. You can see in the animation here, they actually are what control the scaffolding and the clotting. So the disease that our patient has, or TTP, is actually a disease of those green cowboy hats, which we'll get into in a bit more time here. So this is a normal situation in all blood vessels. So what happens is there's a site of injury, then this scaffold inserts itself, and unravels, which then allows the purple platelets to come and form an appropriate type of clot. So that's sort of the normal circumstance, and that's controlled by the green cowboy hats. So for example, you can see this one here, a green cowboy hat would have cut that off so it doesn't make an excessive clot. What happens in TTP, or autoimmune TTP, is the patients actually have these yellow Y-shaped structures, which are antibodies. So they form antibodies against the green cowboy hats. And now the green cowboy hats cannot control the clotting. So what happens now is the patient has these scaffolds that start inserting in an uncontrolled fashion. And you can see it dropping down here in the animation. And then you get a huge clot forming. And so that clot in this diagram is occurring in one blood vessel, but you need to imagine that this would be in all of the patient's blood vessels occurring at the same time and repeatedly in the same blood vessel, cutting off the oxygen supply to the organs and resulting in damage. The other thing that happens because those clots are so large in the bloodstream is you can see these red cells now, which are your blood cells, get smashed into the clot and destroyed. So in addition to cutting off the oxygen supply to the organs because of the clot, this disease also destroys red blood cells, which further impairs oxygen delivery into the organs. So you can see you get a double hit that occurs there. So quite a devastating disease. This is a case study we actually published in the CMAJ, so Canada's most prominent journal, about a patient at our institution. And I wanted to contrast the journey of this patient with our patient advocate, because the patient advocate actually had access to the new medication caplacizumab, whereas this patient did not. So I just want to show you this patient's journey that we've published in the literature. So this person is a 40-year-old man. He actually showed up with intermittent loss of speech. So he was having stroke-like symptoms, and he was assessed in an urgent care, and they contacted the stroke team over the phone, and they actually recommended that he be seen in a stroke clinic. So he got let go from this urgent care clinic to be seen as an outpatient. So right away, you can see something's going on here. There's a 40-year-old healthy person showing up with a stroke. He was noted to have low blood counts, as I showed you in that diagram, and also low platelets. So I didn't mention that, but because all of those platelets are being attached to that scaffold, they're being taken out of the bloodstream, so we can't measure them anymore, and that's why the platelets look low. So this gentleman continued to have recurrent stroke symptoms and presented to our emergency room, where the doctor identified him as having a probable TTP. So the blood doctors or hematologists agreed, and they consulted our service, which is the plasmapheresis service and forms the foundation of therapy. I'll explain plasmapheresis in a little bit, but it's a procedure akin to dialysis, where we sort of clean the blood from the antibodies. So the patient was given plasmapheresis and also immune suppression in the form of steroids or prednisone. And we did confirmatory testing to reveal that this patient did in fact have TTP. So what happened, and what can often happen in these cases, is the patient actually improved over the first 6 days and did well. On the 7th day, he developed crushing chest pain and a hematologic relapse, meaning his platelets dropped again, and his blood cells started being destroyed again, and his organs were suffering again. As we go through the data, I'll show you how often that happens. So the patient actually suffered a myocardial infarction or a heart attack from the disease and experienced cardiovascular collapse. So basically his circulatory system stopped working because his heart essentially died on him. He went to the ICU and died of his TTP complication. So you can imagine that this patient was 40-year-old, young, working person, went from being a strong contributor to society to death within about 7 days. So this case, as I mentioned, predates the medication we'll discuss today, but the question is, should that same patient walk in the door today, can we have access to the medication so that we can help him both from the death, but also the significant disability that can occur with this condition? So this is the current standard of care, and I'm going to highlight a bit of the unmet need. So the first one is plasmapheresis. And so in order to do plasmapheresis, we have to connect you to a machine through a line, and it's sort of like a dialysis line that goes in your neck. And the machine actually cleans your blood from the antibodies that were attacking those green cowboy hats. And it also gives the patient back some functional cowboy hats because we give them plasma as well to replete that. Because this is an autoimmune disease, so your immune system has created that antibody, we also give toxic type medications to inhibit the body from forming more of those antibodies. So the idea is the plasmapheresis removes the green cowboy hats from the circulation, and the immune suppression prevents more green cowboy hats from accumulating or being produced. But as you can imagine, this process takes time, And as that time elapses, the patients continue to experience damage and complications from this disease. And so, and also the current standard of care doesn't directly address the mechanism of this disease, which is why I'm showing you some mechanistic stuff here. So if we look at it in terms of unmet needs with the current standard of care, it's rapidly progressive. So mean time from diagnosis to death is 9 days. Up to 20% of people die with the current standard, as I mentioned before. Up to 42% of patients are refractory, so they don't respond to therapy, sort of like our patient. And the definition of refractoriness is there for you. And they also have a high recurrence rate. So up to 50% of patients will have relapses or exacerbations. And as our patient advocate mentioned, she's relapsed, I think she said 3 times already. So this disease comes back to haunt patients as well. So again, you can imagine the impact that has on disability and work, for example. The plasmapheresis itself has complications related to it. So I'm not going to go through these in detail, but you can bleed, have clots from the line insertions, and there's also other things that can occur from the procedure itself. And again, immune suppression, as you're probably all familiar with, it turns down the immune system. So you're at higher risk of infection and other complications from immune suppression. And again, it often takes a while for immune suppression to start working. So we'll spend a bit of time here discussing Cablivi, which is caplacizumab, and was the box that the patient showed you on her camera there. So this is for the treatment of adults with acquired TTP in combination with plasma exchange and immunosuppressive therapy, and that received Health Canada NOC in February 2020. So if we go back to my animation here, what caplacizumab does, it's actually a nanobody, and you don't have to know too much about that, but if you see these little blue structures here, that's the caplacizumab, and you can see this patient has TTP, so they have antibodies to their green cowboy hats. So the caplacizumab actually binds those scaffolds up where the platelets would normally attach to form a clot. So you can see now, as the platelets drive by, they don't actually hook on to that scaffold and they don't form a clot, thereby preserving the organ behind that blood vessel and also preserving the blood supply as well. So it's a very novel and directed therapy for this condition. So as nephrologists and hematologists and plasmapheresis doctors, what we would like to do is move towards adding a third pillar to the treatment of TTP. So plasma exchange remains a foundation of that. Immune suppression also remains a foundation of that. But can we now add caplacizumab here so that we have immediate direct effect on these very critically ill patients to ensure that we can shut this disease off as quickly as possible while we're waiting for the plasma exchange and the immune suppression to work and get the patients essentially out of the hospital more quickly, and also minimize their complications and disability, as well as decrease the mortality rate. So I'm going to pass over to Rahul, who's going to take you through the Hercules phase 3 randomized double-blind placebo-controlled trial.
Thank you so much, Dr. Gerard. I hope everyone can hear me. Hello, everyone. My name is Dr. Rahul Bohra, and I work in the Medical Affairs Division of Sanofi Genzyme. I'll share with you how we tested caplacizumab, or Cablivi, in a phase 3 clinical trial study and the key results that we got from that study. The clinical trial study is called Hercules, and it was a phase 3 randomized double-blind placebo-controlled study. So it was well controlled. And this study was conducted in 55 hospitals across the world. And the study results were published in the New England Journal of Medicine, as you can see on the slide here. Also, as Dr. Gerard mentioned, that there is an unmet need in patients with ATTP. This clinical trial was designed to answer the question, do the outcomes in ATTP patients improve if caplacizumab is added to the standard of care treatment, which Dr. Gerard just said is plasma exchange and immunosuppression? And the design of the trial is shown on the next slide. Next, please. So there were 145 patients in the study with a median age of 45 years. And as Dr. Gerard mentioned earlier, it happens in the working population. The first episode usually occurs within the 30th or the third or the fifth decade of life. The patients here, as I said, median age of 45 years, they were randomly assigned to either receive the standard of care treatment along with a placebo or the standard of care treatment along with caplacizumab. As you can see on the slide, after the first plasma exchange, the standard of care treatment started, which included plasma exchange, which is shown here on the slide as PEX, PEX, with immunosuppressants such as corticosteroids. Patients received a daily dose of caplacizumab or a placebo during the plasma exchange period, and then following that for 30 days. So first during the plasma exchange period, and then 30 days thereafter. Click, please. The median treatment duration that we found out in the study with caplacizumab was a total of 35 days, which included a total of 5 days of plasma exchange, and then 30-day treatment period post-plasma exchange. So while a high majority of the patients responded to the standard of care immunosuppression that is given first line to these patients, a minority of the patients did not respond to that treatment. And their autoimmune disease persisted even after that 30 days of treatment. So for those minority patients, additional treatment was allowed to protect them from microclots, while more targeted immunosuppressants were used to control the underlying autoimmune disease. As Dr. Gerard mentioned, the yellow antibodies, they're attacking the green cowboy hats. So the disease, until it persists, it will keep creating those yellow antibodies. And what immunosuppressant drug does is stops the body from producing those yellow antibodies. So after completion of treatment in both arms, the one placebo and then caplacizumab, then patients were monitored for a follow-up period. Next, please. Coming to the two treatment arms, we saw that a fast platelet normalization happened such that patients treated with caplacizumab were 55% more likely to achieve platelet normalization. Very importantly here, though, Dr. Gerard mentioned about his case, as well as the patient advocate or the speaker that we have early on, we combined the outcomes of TTP-related death, any kind of relapse, and major thromboembolic event into one outcome. And we saw that the comparative results between the two arms showed a 74% reduction in patients who received caplacizumab, which was statistically significant. Exacerbation is another form of recurrence, and it happens in the near term from the initial episode, and this was also 67% lower in caplacizumab arm of the study, again with statistical significance. As Dr. Gerard mentioned earlier in that slide, which showed that the time to death from the beginning of diagnosis or until death is approximately 9 days, that's shown in other studies. That slide also showed that there are approximately 40% cases in clinical practice where the disease does not respond to treatment. But with caplacizumab in this study, there were no refractory patients. That means that all of the patients that were on the caplacizumab arm or were treated with caplacizumab responded to the treatment, compared to 3 patients in the placebo arm that did not respond to treatment. Also, very importantly, there were no deaths in the caplacizumab treated patients versus 3 deaths in the placebo arm. Caplacizumab also led to reductions in hospital stay by 31%, in ICU stay by 61%. As I said, as the patient advocate earlier said that she was admitted into ICU during her relapse and initial episode, and plasma exchange volume, which Dr. Gerard showed has its own disadvantages, such as allergic reactions, because you're putting someone else's plasma into another patient, as well as the procedure-related complications. So that plasma exchange treatment was approximately reduced by 40%, less than the placebo arm, both in terms of the volume of plasma that was infused into the patient, as well as the number of treatments that were given to the patient. And the safety profile of the drug was found to be predictable and manageable based on its mechanism of action. And now I will hand the presentation back to Dr. Gerard.
Great, thanks so much for that, Rahul.
Absolutely.
So we're nearing the end of the presentation, and then we can open it up for questions. So I'm just going to show you a bit of the dosing and administration, just so you can get an idea of how this will work in the real world. So essentially, the patient will present with TTP and start the plasma exchange, and then receive caplacizumab, and they will get caplacizumab daily for the duration of their hospitalization. So here we're looking at a mean range of hospitalization for this example, and that will be completed in the hospital. Then the patient will continue caplacizumab for at least 30 days after their last plasma exchange. Depending on various parameters and how they've done, that duration could be extended. And this is actually all done at home. And so the caplacizumab here is a subcutaneous injection that's given daily at home. So mean duration of treatment there would be about 27 days. So if we're looking at the mean number of doses for therapy, it would be 38.2 vials as indicated in the green box. So in terms of conclusions then, hopefully you've probably never heard of or cared about TTP unless someone by chance in your family has been affected by it, but it's a very rare disease, but it's one that is very devastating, has a very high chance of morbidity and mortality in a group of young and otherwise healthy working individuals. It has a very high risk of relapse, even with current advanced standard of care, not including caplacizumab, and it also has a high rate of refractory disease. Patients with TTP, as I mentioned, are often of working age, and when treated appropriately in the current context, they require medical leaves during the acute event and hospitalization. They also require short and long-term disability, and as I mentioned before, can suffer cognitive issues, end up on short or long-term dialysis, have heart issues and mental health sequelae as well. And of course, 20% of the time die. Kablivi is a new therapy for TTP that can be used in conjunction with the standard of care. And as we've showed you, received Health Canada NOC in February. It directly addresses the disease process and acts very quickly in order to allow for the other therapies that we've shown you to have time to work. And so based on the data that Rahul showed you from the Hercules trial, it greatly improves remission rates for patients with ATTP. We see less relapse, less refractory disease, and also Rahul showed you the decrease in hospitalization, ICU rates, and death. So in the end, this is all combining together for improved outcomes for our patients. And you saw a very real example of that with our eloquent patient presentation, or patient advocates presentation. So that's all the slides I had, and I'm sure Rahul and myself are happy to entertain any questions that may have come through.
Okay, so thank you so much for such an insightful presentation, Dr. Gerard and Rahul. I'd now like to invite our patient advocates to come back on and do their Q&A session, and then we're going to bring back Dr. Gerard and Rahul to do their own separate Q&A. So patient, if you could come back on. There we go. Hi, sorry about that. I do have a couple questions for you. So in your experience, what helped you in your journey to diagnosis and treatment? Hello? There you are. Sorry, I think you're on mute. If we can just get you to take yourself off mute here.
You hear me now?
We can absolutely hear you now. Thank you so much. So yeah, what's helped you in your journey to diagnosis and treatment?
What helped me? I'm not sure what helped me, but I think my work did. I work with, I'm a youth worker, and so focusing on my students' issues and concerns kind of takes me away from not thinking about TTP.
Okay. And what's been the most difficult aspect of living with this disease?
I think the most difficult thing for me is not too sure when I'm going to relapse, because I can relapse anytime. As I was said, my last relapse, it happened while I was at work. I went on a lunch break and I felt it tends to hit me in the stomach, and I felt quite nauseous. So anytime I feel nauseous for whatever reason, it just brings me right back to, am I going to have a relapse? So I have to live with that every day.
It must be extremely difficult. I'm so sorry to hear that. I think this one might be a little bit obvious, but is it difficult to explain your disease to other people?
Not really. I just let them know I have my immune system is compromised, so I just have to be very mindful around me, and everyone just seems to be okay with it. They don't treat me any different. I haven't noticed. They haven't treated me any different.
Okay. And yeah, my last question for you is going to say, like, having a rare disease, do you think people treat you differently? But you just said the contrary. So is there anything else that you'd like to add or address before we say goodbye and bring the doctors back on?
No, I just like to just thank you for allowing me to share just a brief part of my story. It is a tough journey for anyone living with TTP. And I'm not sure how I got it, because when I asked, how did I get this disease, they said it was airborne. And so that doesn't really bring it down to one thing. So my life is sort of living in a bubble, but I won't let it stop me from living. Thank you.
You're incredibly brave, and I really appreciate you taking the time to share your story with us today. So thank you so much, and I hope you have a really great rest of your day.
Thank you so much.
Okay. I'd now like to bring Dr. Gerard and Raul back on for us to have their Q&A. And Raul. Alrighty.
Yes.
So our first question for the both of you is, let me see, there's so many. Knowing TTP targets young people who, knowing TTP targets young people, who is at risk of TTP? Smokers, male versus female, etc.
Yeah, so that's a good question. So it's a disease that doesn't tend to discriminate sort of by any predictable demographic in that way. Frequently, we think of autoimmune diseases as being more prevalent in women, although you know, the dispersion here would vary based on the groups that you're looking at. So, you know, there are actually genetic forms of TTP, and we're not discussing those today because the treatment of that disease is different than the acquired form of it. But certainly, if you were in certain groups or families, you might be at higher genetic risk of developing TTP. So overall, I would say, you know, there's not a predictable reason why anyone in particular gets TTP.
Okay. And is there some way to determine if this product is working during the 9 days in the hospital before the patient is discharged home?
Yep. So the way we do that is we predominantly want to have a look at what we call the hematologic response, or the response in the blood vessels. And so what we want to look at is to make sure that the platelets themselves are starting to climb back up and they're not being consumed in the blood vessels. And we also, as a secondary component to that, want to assess and make sure that the blood cells themselves are not being destroyed. So we can assess that with other blood tests as well. After that, we want to oftentimes see that organs are getting better. So oftentimes the easiest one to do that is the kidneys, because we can measure that with a blood test. But depending on how the patient's presented, we want to make sure that their organs are improving as well. The important part with Keblevi is that, you know, it does address the underlying mechanism of this disease and turns it off very quickly, but we still do have work to do with the immune suppressing drug to prevent the bone marrow from making those yellow antibodies we showed in the presentation. So it's a very sort of complex disease that requires very frequent assessment, even when the patients leave the hospital.
Okay, and how long can it take to diagnose a patient and start treatment?
Yeah, so that's an interesting question. So we think of this disease as being quite fulminant, and if it gets out of hand, it can be fatal. But as I showed with my patient that we published in the CMAJ, he was out in the community for at least 3 days with his symptoms before he was identified. And I've had other cases where they've had sort of weeks of symptoms before they're identified. So all of it has to do with how fulminant of disease they have. But the danger of it is that if it's not identified, the longer it goes, the more likely they are to die. And the later we see the patient in their disease process, again, the more likely they are to die or have a significant complication. And as you can imagine, like in medicine, we often speak of horses and zebras. So horses would be kind of more common diseases and zebras would be more rare diseases. And this is definitely a zebra. So a lot of people don't have this in the forefront of their mind. So, you know, we do spend a lot of time educating even our own blood doctors and kidney doctors and intensive care doctors and emerge doctors and family doctors to try and keep an eye out for it.
Okay, and what would you say is the life expectancy of these patients?
So that's a great question that I don't have a good answer to. It really depends on how much they are affected by the disease as it comes in, and that life expectancy would be driven sort of by the underlying complication that they suffer. So, for example, if they suffered end-stage heart failure, their life expectancy would be less than 2 years. If they ended up on dialysis, the average death rate is about 20% a year on dialysis. And then if you start compounding those things together, you can see that there's a potential to shorten someone's life significantly. However, the flip of that is that these tend to be young, resilient people. And so when we catch the disease early and they don't accumulate too much morbidity, they can actually have exceptionally like normal life expectancies without much complication. So I think, you know, that's why I'm a big advocate of knowledge so that we can see this quickly. And then once we get the patients is treat them quickly in the best way possible. And again, I'll use my case as an example. This 40-year-old man, even though it took about 3 days for him to get identified in the community, he was treated very appropriately and very quickly, yet still passed away. So I think that highlights that unmet need in this disease of having even better tools, and here, you know, the caplacizumab to shut the disease off as soon as humanly possible, so that we can avoid an outcome like that down the road.
Okay, and another one would be, is this drug administered only in hospital, or can patients do so from the convenience of their own home?
So I'll defer some of that to Raul in terms of the technical aspects of it, but and I'm not sure if we're sharing the slides or not, but there's a slide where we show dosing administration. And so the first part of it is done in the hospital. And then once the patient is discharged, the next part of it to complete 30 days after plasmapheresis, is done at home. And it's a subcutaneous injection that can be done at home once the patient's left the hospital. So the initial shorter part of it will, hopefully the shorter part of it will be in hospital, and then the longer part of it will be at home. But I'll defer over to Raul for anything I might have missed there.
I think you pretty much covered it. In studies, we saw as I mentioned earlier, that there was that 5 days at a median time of plasma exchange where clepagliflozin was used. And usually shortly after that, the patient is discharged. The hospital stay can be, between 5 to 10 days, depending on what they presented. As Dr. Gerard mentioned earlier, the initial presentation can be brain related, it can be heart related, it can be kidney related, etc. So whatever care is required for that, usually for that time, the patient is in the hospital. And that in that slide, as Dr. Gerard was mentioning, was approximately 9 to 10 days. But after that, the patient goes home and they are able to self-administer this. It's a subcutaneous injection, and it's a daily dose for the remaining 30 days after stopping plasma exchange.
Okay. And I know we talked about demographics and who's more at risk for developing this disease, but do you have any numbers on like how much of the general population is affected by TTP?
Yeah, that's a really good question. And Raul, if you want to add anything too, that's fine. Initially, when I trained, we said that the incidence of the disease was around 1 in a million, but I think it's much more common than that, because this is a disease that's been like the mechanism and how to diagnose it, it's been identified more recently, like for example, in the last 20 years. And so we've become a lot more adept at finding it. And so the disease incidence can be, 1 in 100,000 to 1 in a million, depending on the areas you're looking at. But I can tell you, last year in Calgary, and we cover a catchment area of about 3 million people. We don't cover just Calgary. We had 17 cases of TTP. So even though it's rare, we still see it at a good clip in Canada.
Yeah, and just to add to that, in the clinical trial study that I discussed, we showed predominantly, and Dr. Gerard mentioned this as well, that autoimmune disease tend to impact women more so than men. So approximately 70% or 69% of the patients were female in that study, and majority of them were white as well. And when it comes to autoimmune disease, race also plays a factor that, this is more prevalently seen in, let's say, African American population or the Latino population. So there are some minor trends there, especially given the female part of it, that that's prevalently seen everywhere across the world. But in terms of race, because it's a rare disease, the studies are currently ongoing. And in fact, some data was presented last year in ASH about the racial demographic of this disease. But autoimmune disease in general have some of those patterns.
Okay. I only have 2 more questions for you guys, so hang in there. What are the long-term complications that you usually see from this disease?
The long-term complications. So I found, again, I'll tell you a bit about personal experience and some of the data set, but I found that almost every single patient with TTP has cognitive issues afterwards, and also issues with their mental health. So things like depression, they're very common, and they're also hard to detect. So it requires someone taking time with the person to figure those out, because humans are very good at masking cognitive issues, especially when they're young. But when you delve into it, you can see that it's actually a predominant feature. So that one is almost universal and very prevalent, or those two. After that, so the main things we would talk about would be kidney disease, and whether or not they require short or long-term dialysis as a result of that. Heart problems, and the main long-term consequence from heart disease, if you don't die of it, would be heart failure. So daily chronic shortness of breath and fatigue because of the heart not working properly. And then after that would be things like stroke. So having limb paralysis or, visual field defects or, the cognitive issues that I've discussed before. And then, actually we probably shouldn't minimize this, but I think the patient advocate did a great part of that. Is you can see the anxiety around the condition as well and worrying that it's going to come back. So I think, it's a disease because it affects the blood vessels can affect any organ and have sort of any long-term organ dysfunction complication there. But those would be kind of the common ones that we look for.
Yeah, and if I can add to what Dr. Gerard said was, I don't know if you remember in the earlier slide, about 60 to 70% of patients show the neurological symptoms. As you can imagine, those small vessels are there in the brain, and if they get blocked, the blood supply and the oxygenation to that region of brain stops. If the disease is addressed really quickly, like the diagnosis very fast, you get plasma exchange in. If the access to Kebbi is there, it arrests that clotting in its place. But if it goes on for a little bit longer, then there can be permanent neurological damages for future. And that neurological part, basically changes the quality of life of the patient going forward because of, as Dr. Gerard mentioned, the anxiety of what's going to happen, as well as the impact on the brain that disease makes. So long-term complications are quite severe, and because of that, the treatment and diagnosis should happen as soon as it can.
Right, so my next question was going to be about kind of like overall quality of life of patients, when they recover from an acute episode, but maybe just given the audience that's on the phone today, maybe we can discuss, like, from a workplace perspective, like, how does this affect people in the workplace? Like, how would this affect an employee, like, and their ability to function at their job?
Yeah, I think it's an important question to address because, again, the population this is affecting are largely kind of the young working force, and so it can affect it significantly. So, I mean, in the acute phase, obviously they're off of work because they're hospitalized, and in very severe cases, that hospitalization can be weeks and months. And then after that, there's rehabilitation required, depending on, again, the complications they've suffered. And so frequently we see patients not only off of work when they're in the hospital, but then on short and long-term disability based on the side effects that they've suffered. And those may last weeks, months, or years. For example, if you've had a stroke and you have paralysis of half your body, that may be something that never recovers. So, I think the impetus here is to try and treat these patients aggressively early so that we can minimize the impacts of this devastating disease and get them back to work earlier. When we're looking at return to work, again, we might also have to do return to work modifications and, shortening of the workday or things like that to accommodate things like cognitive issues or fatigue, or, again, mental health issues that would surround the sequelae of this disease. So I think, it's a disease that affects young, resilient people in quite a devastating way. And so, getting these people back as healthy as possible, I think it is key. And we do that, in a percentage of cases, we have patients that have a milder course of this disease, but then again, we have patients that have very severe relapsing refractory courses, much like our patient advocate mentioned as well.
Okay. Roel, do you have anything that you'd like to add before we end?
Oh, that was it. Dr. Gerard covered it. Absolutely.
Okay. So that's, unfortunately, that's all the time we have for questions. So thank you for your questions and such an informative discussion, everyone. And I'd like to thank our speakers, Dr. Louis Gerard and Dr. Rahul Bohra, once more for sharing their afternoons with us today. And I'd also like to thank our sponsor, Sanofi Genzyme, for their support and hard work leading up to today's digital event. And thank you to everyone for tuning in. When you exit today's webinar, you'll be prompted to answer a survey. We'd appreciate if you took the time to provide your honest feedback, as this is integral to the planning of future webcasts. Have a lovely evening, everyone. Stay safe and look after yourselves and loved ones.
Thanks, everyone.
Thanks, everyone.
Bye.